Hi, thank you for taking the time to listen to this short video, and I hope it helps you when planning and assessing a tooth removal. This video should be used as a guide, and I'll explain the way that I assess teeth when I'm planning a tooth removal. I will mention that I am not a specialist in oral surgery, but I will outline some examples of cases that have been referred to me in the last 12 months. Okay. What do I look for when I'm assessing a tooth for removal? There's a lot of factors that are self-explanatory and we do automatically, like age and gender, medical history, whether someone is on an anticoagulant, extraction history as to whether someone's had a challenging tooth removal previously, looking at the lower jaw profile, seeing if that person's got a larger lower jaw, and that might lead me to think that that might be a slightly more challenging tooth removal. Obviously tooth position, whether it's anterior or posterior, root anatomy, the number of roots or the bulbosity within the roots, whether the tooth is already mobile. This can sometimes be a red herring because the coronal portion can be loose, and when we come to elevate these teeth, we realize there is still some part of the roots which is still embedded. Looking at the adjacent bone support, how much tooth is left above the bone line or the gum line, history of any root canal treatments. I tend to find that root canal treated teeth tend to be slightly more brittle. If there's any apical radiolucency, this might lead me towards curetting the area just to prevent any type of infection or residual cyst, and help the healing of the bone afterwards. Mouth opening and any jaw joint difficulties. This can sometimes lead to sedation for tooth removal if someone struggles with mouth opening or has jaw joint issues. Obviously, looking at the anatomy of the maxillary sinus or the inferior dental canal, and obviously, finally looking at acute infections, and this will alter the way in which I might deliver my local anesthetic to achieve a pain-free tooth removal. Okay, I'm going to go through some examples now with you. So we have an upper right 7, which looks to have significant bone loss around it. This tooth is mobile, and so I expect that the removal of this tooth would be straightforward. There is some proximity to the maxillary sinus, and sometimes these cases there is an initial communication, but almost always that communication is closed off when the socket heals. Now we're going to look at this upper right 6, which is split or is cracked. And when I'm assessing this, I'm always, as a backup, considering dividing this tooth into its 3 separate roots. And this is what I did in this scenario. So we went to apply some pressure through the tooth. I felt that the tooth was still firm within the gum and in the bone. So I quickly moved towards just separating the roots, and removing them in 3 individual parts was the most straightforward way of removing this tooth. We're going to look at upper wisdom teeth, and generally, again, as a rule of thumb, not always, but often upper wisdom teeth can be straightforward to remove. We have to be mindful of the tuberosity and any type of communication with the maxillary sinus. But there's no restoration in the upper left 7, so I feel confident in elevating the mesial aspect of the upper left 8. And sometimes I'm holding the tooth or holding the gum, buccal and palatal, to feel for the movement of the tooth as I'm elevating, especially if I'm not able to directly visualize the tooth due to access. We're going to have a look at some lower teeth, and again in this scenario we have a tooth which is heavily restored. I do expect that when we come to remove this tooth, that the top of the tooth would break off, and this is exactly what happened. But I also have to be mindful of the adjacent restorations in the lower right 7 and the lower right 5. For that reason, I'm probably looking at, again, either separating the roots, and I did separate the roots, and my elevation point won't be the mesial or distal of the lower right six. It will actually be the furcation area, and this will allow me to confidently apply pressure through the roots with confidence that I'm not going to damage the adjacent teeth. So we spoke a little bit about root canal treated teeth, and again, fortunately in this scenario, there's been a little bit of bone loss into the furcation. So we have an application point, which is the furcation. Again, the roots will be removed individually. It's going to be almost impossible to remove this in one piece. It will sort of fracture and break. But we look at the apical lesion, and I'm automatically thinking that I'm going to be curetting this lesion just to help with any bony healing after tooth removal, and obviously speed up recovery for this patient. Talk a little bit about wisdom teeth here. So we have a lower right wisdom tooth. There is not a distal restoration on the lower right 7, so I have some confidence in applicating the mesial aspect of this wisdom tooth. It's got a conical root form. We have about 1 millimeter from the inferior dental canal. So these types of wisdom teeth can be straightforward in their removal, and this one was, fortunately. We'll look at a different type of tooth removal, and this was an attempted tooth removal that was referred to us. There's a temporary restoration on it. The lower right 7 has a crown, and I always warn these patients of potentially the crown de-cementing and me needing to re-cement the crown back on. But my application point is going to be slightly different. We have 2 separate roots. We've got quite a big distance from the inferior dental canal, maybe sort of 4 to 5 millimeters. But again, we're looking at most likely the roots separating, so removing the mesial and distal roots separately, but my application point will be the furcation area. This is where I'm going to be able to confidently apply pressure onto the roots to be able to elevate this, and that's how this tooth was removed. I'll now look at the lower left wisdom tooth. Removing this tooth will be a surgical process. We can see some proximity to the inferior dental canal. This is where we have to inform patients of risk of damage to the ID nerve. The access will be via a flap approach, removing some bone, sectioning the tooth into some different parts and removing those parts individually, and then achieving good soft tissue closure after tooth removal is ideal to speed up healing. We can see on the distal of the lower left 7 there may be early decay. I'm asking regular dentists to just assess these areas over time, because we can notice that sometimes these areas remineralize, and there's no need for any restoration in the lower left 7 long term. Looking at the lower left wisdom tooth now, we see a slightly different scenario. There's no impaction, but the root form is bulbous. We can see significant overlap to the inferior dental canal. We can see some deviation in the canal as well. And in scenarios like this, I'm considering a coronectomy. So this is just removal of the top portion of the crown. This patient was suffering with pericoronitis, and if we're able to get a good gingival seal afterwards, we can relieve these symptoms for this patient, and also prevent any sort of